47-year-old female, Caucasian, with no family history of GI neoplasms. She's a non-smoker, does not drink. She has Hashimoto's thyroiditis and previously underwent a cholecystectomy. She also has a CFTR mutation conferring chronic calcifying pancreatitis, for which she was treated in 2004 with a pancreaticoduodenectomy. Between the years of 2006 to 2013, she didn't have any recurrences of her acute pancreatitis. And then in 2013, she was treated with a partial gastrectomy with Roux-en-Y anastomosis due to a volvulus. Then last year, she did have a recurrence of her pancreatitis, the last one being in March of this year. She underwent an abdominal ultrasound, which showed a normal remnant pancreas, and had blood exams that showed elevation of her amylases and a significant elevation of her lipases, as well as a decrease in her normal hemoglobin levels. An MRCP secretin test showed no focal lesions with an irregular morphology of the main pancreatic duct, but then regular outflow through the Wirsung jejunostomy. Today, she will be undergoing an endoscopic ultrasound performed by Dr. Garcia and Dr. Sahai.
And it's true that this is a very interesting case because, as you've already been told, this patient underwent a gastrectomy, almost total gastrectomy, so it's quite complex to make a nice EUROEUS image of the pancreas, because we need to be aware that we can only insert the scope just like a few centimeters inside of the remnant gastric part, and we need to be aware that when using a linear scope in a surgically resected gastric patient, it can be some complications if you freely go in and out of the anastomosis. So it's very important to go in endoscopic view to see if we can turn to the endoscopic view. We can just take a look that we are really place the scope in the stomach, and at that then we need to change, like when we're doing a standard EUROEUS from the remnant stomach very close to the GI junction to try to focus the pancreas. And now we will have the EUROEUS image, and Anand is helping me. We have just now focusing in the pancreas.
There's the duct right there.
Now Anand is showing the main pancreatic duct. And in this case, it's very important to know the causes, the relapsing of the episodes of acute pancreatitis. What we are first learning from this EUROEUS image is that the patient really has changes according to chronic pancreatitis. We have a mainly hypoechoic parenchyma, irregular, heterogenic, with stranding, with foci. We can say there is an lobularity, mainly almost honeycombing lobularity. So we are, if we go to the Rosemont classification, we have 3 of major B criteria and 2 minor criteria. And now we need to focus, and in this case specifically, in the main pancreatic duct, because we need to find if the causes of the relapsing episodes of pain are related to some kind of obstruction, although we know from the MRCP that this was a normal outflow. So now we are focusing, and Anand is helping me with the main pancreatic duct. Now, we know that the patient has not head of the pancreas, so now we are going to focus in the body and tail, of course. Now we are in the confluence with the splenic vein, portal vein, and superior mesenteric vein. So what we have in the upper part of the image is the pancreatic parenchyma from the body. And the first thing that we need to find is the main pancreatic duct. That is quite complex in these cases with those so many strands.
Yeah, with severe chronic pancreatitis, it can be actually quite hard to find the duct. I think it's probably here.
There where Anand is showing it. But sometimes it's quite complex, and also we can clearly see those white spots that are the foci.
Yeah.
So we need to go, and also it's important to try to see the relationship of the main pancreatic duct with the lumen of the jejunum, that it's over there, where the anastomosis has been done between jejunum and the main pancreatic duct, and I think we have it over
right
there.
Here, right
exactly.
Here, I think, yeah. You see, it's wide open. Huh? There's no stenosis there. I think it looks good.
Yeah. So the next step is to follow the duct till the tail of the pancreas to see if there is any kind of change in the caliber, diameter, or if we found any kind of lesion inside of the duct.
Remember that the pancreatic duct always has to get smaller when you go to the tail. So whenever it gets larger going to the tail, that's not normal.
So we keep focusing the image by torquing clockwise the scope. Slightly torque.
Is that, if that's the duct, it's getting big, huh?
Yeah, so we use the Doppler to find out that we have the duct there. And as you see, there is a slight change in the caliber of the duct.
Oh, it's all right. So take this. You want to take it off? I can point after that.
Okay.
Yeah. Okay. So here it looks larger than it was. Yeah. So then, if you see that it gets larger, then you have to go back and see at the transition zone. Is there something blocking at that point?
So we're now just moving slowly anti-clockwise again to try to go to the origin.
Yeah, and look.
So sometimes it's even different to differentiate between some dilated collaterals. But there's some white spots.
This one here. So there's the duct. And right here, see?
Yeah.
And sometimes you can find very small stones that they don't see on the MRI that are really in the duct. And if you can show that the duct right after that stone becomes dilated, it makes sense. Then you really do have an obstruction of the main pancreatic duct by a stone.
In fact, if you can see here, if we have the
it's here.
Trying
there,
to focus.
yeah. There's the stone right there. Yeah.
I think I agree. I think what the premise of this may be a small stone inside of the duct, that because that white spot with tends to have shadowing there, and when we turn clockwise to go to the tail of the pancreas, we see a dilation related to that small, probably a stone. What do you think, Anan?
I think it's possible. So if she could be having recurrent acute pancreatitis due to obstructive pancreatitis here in the tail, because this duct here is definitely larger than it was closer to the anastomosis.
And in fact, it seems in this point there is a slight enlargement of the duct wall that may be related to an inflammatory process, a recent inflammatory process.
Yeah. Obviously, also, whenever you see an obstructed pancreatic duct, the other thing is a possible cancer. But if you see the stone really in the duct there, I think that's quite reassuring that there's nothing
and
dangerous.
If not, we can use elasto in this point that it can be helpful, although in those cases, just to focus the elasto, you see the duct in the red image, and if you follow the red image, we do not find really any really blue area related to the duct that can exclude quite nicely the presence of a cancer in this patient. So maybe it's just small stones obstructing the outflow, not seeing in the MRCP, but we know that we are much more sensitive for the detection of small stones, not only in the bile duct, but also in the pancreatic duct. So this is why EUROEUS became so important in the evaluation of these kind of patients. So as far as we know from the results of our EUROEUS exploration, we can conclude that this is changes for chronic pancreatitis, clearly changes of chronic pancreatitis.
That's nice.
There's again another image of the main pancreatic duct, again dilated.
Quite larger, yeah. See, and so and the MRCP, if I understood, said the duct wasn't dilated.
No.
But for this person, this is a dilated duct. Her pancreas is very atrophic, and the duct is.
And there is another white spot here that may be related to a stone that we have seen here, because we turn. We've just turned and we have the duct there, and there is a stone there, a stricture with a white line with some shadowing, maybe.
Yeah. Interesting. Interesting.
So I will say this is a chronic pancreatitis for sure in the context of a CFTR mutation that we know that is related with chronic pancreatitis. And probably the origin of the episodes of pain is the presence of small stones inside of the main pancreatic duct. So maybe we should
Lithotripsy?
discuss
Lithotripsy or
lithotripsy
something?
maybe, or try to make a very complex CRCP.